Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Outcomes Following Central Nervous System Direct Therapy for Childhood Acute Lymphoblastic Leukemia, using triple intrathecal therapy with delayed administration of first triple intrathecal therapy until disappearance of peripheral blood blasts, by Professor Derton Liang and colleagues. My name is Cheng Hong Pui, and I am the chair of the Department of Oncology at St. Jude Children's Research Hospital in Memphis, Tennessee, USA. My oncologic specialty is pediatric leukemia. One of the challenges in treating children with acute lymphoblastic leukemia has been eliminating the use of prophylactic cranial irradiation without compromising leukemia control. Earlier studies from St. Jude and the Dutch Child Oncology Group showed that with effective systemic and intrathecal therapy, prophylactic cranial irradiation can be safely omitted without compromising patient outcomes. To be successful, however, this approach requires optimal administration of intrathecal therapy. Previously, we showed that the traumatic diagnostic lumbar puncture that resulted in leukemic blasts being inadvertently introduced into the cerebrospinal fluid was associated with poor treatment outcome. The reasons for the poor outcome included 1. Seeding of leukemic cells in the central nervous system. 2. Collapse of the thecal sac as well as scarring or cementation of the subarachnoid membrane, which all compromise subsequent intrathecal therapy. And 3. Masking of overt central nervous system leukemia through contamination with blasts from peripheral blood. To reduce the risk of traumatic lumbar puncture with blasts, Manabe and colleagues from the former Tokyo Children's Cancer Study Group developed a novel approach. The method involved delaying the initial lumbar puncture and administration of intrathecal therapy until after 1 week of upfront treatment with single-agent prednisolone. While this approach, as expected, resulted in a low rate of traumatic lumbar puncture with blasts, its potential for preventing central nervous system leukemia could not be demonstrated. That is because the high-risk patients received prophylactic cranial irradiation. In the current study, which enrolled patients from 1999 to 2010, Liu and colleagues in the Taiwan Pediatric Oncology Group used multi-agent remission induction therapy to reduce circulating blasts. The authors also delayed diagnostic lumbar puncture and triple intrathecal therapy with methotrexate, cytarabine, and hydrocortisone for up to 10 days following diagnosis. They were careful to avoid undue delays in administration of intrathecal therapy, which has been shown to adversely affect outcome. The researchers also took multiple measures to decrease the occurrence of traumatic lumbar puncture with blasts. Those steps included platelet transfusions to correct thrombocytopenia prior to the first lumbar puncture, deep sedation of patients during the procedure, and assigned the most skillful practitioners to perform the lumbar puncture. Of the 152 eligible patients in the study, 22% had circulating blasts when the first lumbar puncture was done, but none of the patients had leukemic cells in the diagnostic cerebrospinal fluid. Therefore, none of the patients had traumatic lumbar puncture with blasts, CNS2 or CNS3 status. Patients in this study received risk-direct therapy, including 14 to 20 triple intrathecal therapy for those with center-risk leukemia, and 17 to 23 triple intrathecal therapy for patients with high-risk disease. Prophylactic cranial irradiation was not used in any patients. The treatment results were excellent. With a median follow-up of almost 7 years, the 5-year event-free survival for patients in the study was 84%, and overall survival was 91%. Importantly, only 2 patients experienced a combined CNS and hematological relapse, and no patients developed an isolated CNS relapse. That translates into a cumulative risk of CNS relapse of just 1.4% after 7 years. Of the 2 patients who relapsed, one was an infant with MLL rearrangement who subsequently died of refractory leukemia. The other, a patient with E2V6-RUNS1 leukemia, had been alive in second remission for 1.3 years at the time of the report. This study is important for several reasons. The results confirm that with effective systemic therapy and optimal administration of intrathecal therapy, prophylactic cranial irradiation can be omitted, even in high-risk patients. Second, the findings show that delaying the diagnostic lumbar puncture and administration of intrathecal therapy until circulating blasts are largely clear may reduce the risk of traumatic lumbar puncture with blasts. That would eliminate the need for additional intrathecal therapy. This benefit is particularly important for countries or centers with limited resources. However, as acknowledged by the authors, the study's findings must be confirmed. The research involved relatively few patients, just 11 with T-cell ALL, 6 pre-B ALL with a T119, 7 infants, and 14 patients with presenting leukocyte counts over 100,000 per cubic millimeter. Finally, we do not know how the patients with overt CNS leukemia, so-called CNS3 status, would have fared if the diagnostic lumbar puncture was delayed. Historically, patients with overt CNS leukemia are at risk of both CNS and hematological relapse. In this study, pretreatment with systemic chemotherapy might have eradicated leukemic blasts in the cerebrospinal fluid and masked the presence of CNS3 status in some patients. Despite these limitations, this research serves as a stimulus for additional studies designed to optimize CNS-direct therapy for patients with leukemia. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.